Initial management of acute myocardial infarction, AMI, involves the rapid diagnosis and initiation of appropriate treatment to restore blood flow to the heart muscle and prevent further damage. This can be divided into several key aspects. Recognition and diagnosis. Prompt recognition of symptoms such as chest pain, shortness of breath, sweating, nausea, and lightheadedness is crucial. Patients should be urged to seek medical attention immediately if they suspect AMI. The diagnosis of AMI is typically based on clinical symptoms, electrocardiogram, ECG, findings, and cardiac biomarker levels, such as troponin. ECG changes, including ST segment elevation or new bundle branch block, are indicative of AMI. In cases where the diagnosis is unclear, additional testing such as echocardiography or coronary angiography may be performed. Early pharmacological therapy. Aspirin should be administered as soon as AMI is suspected, as it helps inhibit platelet aggregation and reduce further clot formation. Oxygen therapy should be given to patients with low oxygen levels or respiratory distress. Nitroglycerin may be administered sublingually or intravenously to relieve chest pain and reduce ischemia by dilating coronary arteries. Opioids may be used for pain relief if nitroglycerin is ineffective or contraindicated. Other medications, such as beta blockers, ACE inhibitors, or statins, may be initiated depending on the patient's condition and medical history. Reperfusion therapy. Reperfusion therapy aims to restore blood flow to the blocked coronary artery and salvage the heart muscle. It can be achieved through either fibrinolysis or percutaneous coronary intervention, PCI. Fibrinolysis is the administration of thrombolytic agents, such as alteplase or tenecteplase, to dissolve the clot causing the blockage. PCI involves the passage of a catheter into the blocked artery to mechanically remove or dissolve the clot. It is the preferred reperfusion strategy if it can be performed within 90 minutes of the patient's arrival at a PCI-capable hospital. The choice between fibrinolysis and PCI depends on several factors, including patient presentation, time since symptom onset, and availability of PCI facilities. Monitoring and supportive care. Patients with AMI require continuous monitoring of their vital signs, ECG, oxygen saturation, and urine output. Intravenous fluids may be administered to maintain hydration and cardiac output. Pain relief should be provided to alleviate discomfort and reduce the risk of complications. Bed rest is typically recommended initially, followed by early mobilization once the patient is stable. Psychological support is important for patients, as AMI can be a traumatic event with significant emotional implications. Secondary prevention. Initiating secondary prevention strategies is crucial to reduce the risk of future cardiac events. This includes prescribing medications such as beta blockers, ACE inhibitors, statins, and antiplatelet agents like clopidogrel or dual antiplatelet therapy. Lifestyle modifications, including smoking cessation, regular exercise, a heart-healthy diet, and stress management, should also be encouraged. Cardiac rehabilitation programs can play a vital role in educating patients about lifestyle changes, managing risk factors, and enhancing overall well-being. In conclusion, the initial management of AMI involves recognizing and diagnosing the condition promptly, initiating pharmacological therapy, considering reperfusion therapy, providing supportive care, and implementing secondary prevention strategies to reduce the risk of future cardiac events. Collaboration between emergency medical services, hospitals, and healthcare professionals is essential to ensure timely and optimal management of AMI.